One thing that's periodically in the news, and I confess that I'm partly to blame for that, we hear about making new bladders out of stem cells and making those and implanting those and using those. Advantages, disadvantages, any difference between that and constructing these internal reservoirs?
So these reconstructive or tissue regenerative constructs, if you will, are in the very early phase of testing. We happen to be involved with one of the companies that has an early, what's called a phase 1 study that's beginning to look at taking a patient's adult stem cells. These are taken from a small cube of fat from the subcutaneous tissues. This is sent to the company, and these are plated onto a tube that basically is sort of a tissue tube, if you will, basically serves as a scaffold. These cells are incubated in growth factors for a period of several weeks, and then this tube is delivered at the time that the cystectomy is performed. When the bladder comes out, this tube is implanted. It's wrapped in a vascularized structure in order to try and maintain the viability, keep this tube alive while it's continuing to develop. And the thought is that we would not have to use intestinal segments if this all works out. The science is sound for this tissue regenerative technology, but right now we're in the translational phase, if you will, bringing this from the scientific bench or animal modeling into people. But this is still rather early. So at this point, this is really not something that's offered off of these early protocols.
Mm-hmm. Not quite ready for prime time yet.
Not quite ready.
Okay. Dr. Bajorn, when is, aside from the chemotherapy that's done sort of right off the bat, the neoadjuvant chemotherapy, when is chemotherapy appropriate for, as you were talking about, advanced disease, and is there anything else that's in the works that will improve on that end, on the advanced disease side?
Well, this is changing dramatically. So patients who have developed metastatic disease, that is, the disease has traveled to lymph nodes or lung or bone, liver, for example, are candidates for systemic chemotherapy. And the therapies are really developed based on the tolerance of the patient and the long-term goals. So, for example, if we have patients whose renal or kidney function is not satisfactory, we may use one type of chemotherapy. And patients whose kidney function is really superb will use another type of chemotherapy. Following up on that, patients who have good kidney function, and even though they have metastatic disease, they are still potentially curable with chemotherapy. And that's not something that gets enough in the way of notoriety. It really needs to be headline news. So we actually have formulas for looking at the prognosis of patients and whether they are highly curable or not. And in those patients, we will be extremely aggressive with regard to chemotherapy. Now, chemotherapy is not what it used to be. We have ways of protecting the kidney now that we didn't have years ago. We have ways of reducing the nausea and vomiting that used to be seen historically. And there are newer therapies now adding what we call targeted drugs to therapy. There's actually a trial going on in the United States looking at a drug that affects what we call angiogenesis, or the ability for the cancer to develop new blood supply and feed itself. And so there's a study going on with that.
Tell me what you mean by targeted drugs, because that's kind of the buzzword in oncology these days, and I want to make sure that people understand what that means.
Well, this is an absolutely fascinating time for us to be studying the biology of this disease. We can now look at the whole genome, every single aspect of the DNA in patients' tumors. You can shortcut it a little bit and look at what we call whole exome, which is the functioning part of the DNA. But I'll use an example of a case we had recently. We used a drug which is not experimental, but not used for this disease. It's used actually for kidney cancer. And this patient had a superb response to this single drug, and it's an oral drug. And it's targeting a very specific area in another cancer. But in using this drug, this patient now is disease-free 3 years later. She had metastatic disease. She had her disease failed to respond to standard chemotherapy. Our colleagues in the laboratory actually got her DNA and completely sequenced her entire DNA, and we were able to identify that she had a mutation in 2 specific genes that appeared to be cooperating with each other to drive this tumor. That's what we call driver mutations, or they really set the tumor to grow. And in fact, this specific oral drug targeted the mechanism of those 2 genes, and that's why she is in complete remission now. So there's a very strong effort now to identify these driver mutations, or mutations that may inhibit the brakes, so to speak, and to take drugs that we know work on these specific targets and use those drugs in the patients who have those specific mutations. And that's what's called targeted therapy, to be able to target the exact driver of the cancer. We're doing more of that now in patients, and now that we have the tools to be able to do that, to be able to sequence the patient's tumors.
Interesting. I want to get back to the future in a minute. But Dr. Kohlmeyer, we have a question here that I think is, at least for men, obviously high on the list here: erectile function and radiation therapy.
Well, specifically for bladder cancer, there haven't been a lot of studies on specifically looking at the erectile outcomes. There was a very small study from Boston that looked at erectile function, and it seemed like the erectile function was very good, but I really don't think that we have a good understanding of all the different factors that affect erectile function in our bladder cancer patients, or how our therapies really affect that function. I think it's, and I always counsel my patients that it's a risk of treatment, both radiation therapy and surgery. We try to do our best to protect the erectile tissues, but you know, it is a risk of treatment.
Mm-hmm. And erectile dysfunction after radical surgery, that's usually an issue?
So because of the age of many of the men that are coming into surgery, and the fact that many of them have smoked and have some other medical issues, there's been a significant drop-off in erectile function prior to surgery. Surgery in that setting usually does lead to a further diminishment of that erectile activity. But for men that are coming into surgery that have functional erections, there are techniques that we've used for many years that can spare these nerve bundles. These are the nerves that basically stimulate erections. And what we have found is that our nerve-preserving surgery can restore erectile function to a similar degree to what we see when men have their prostates removed as well. A lot of the ability to retain that erectile activity is related to the function prior to surgery. But again, for men that come in with functional erections, there absolutely is a nerve-preserving option that's available. We use it regularly when it's appropriate, meaning that there's no cancer in the area where these nerve bundles are located. We certainly would never do anything that would jeopardize removing the tumor. But for many men, it's an appropriate type of procedure, and it can absolutely lead to a functional recovery.
One extra thing that I'd like to add is that we're actually borrowing some data from our prostate cancer patients, because there's a lot more information and data on erectile function for prostate cancer patients who've had radiation therapy. And what we believe is the mechanism of erectile function dysfunction in those patients is really a vascular injury, that there's diminished blood flow to the erectile tissues caused by radiation, and that subsequently leads to erectile dysfunction. And we recently completed a study in our prostate cancer patients where half the patients received Viagra to take daily to try to enhance blood flow to the erectile tissues and to protect them, and half received a sugar pill or a placebo. And it looked.
This is during radiation treatment?
This is immediately after radiation therapy for about 6 months. And taking these medications daily may have some protective effect on erectile function. And that's just some interesting new data that's emerging that may help diminish erectile dysfunction in all of our patients.
Interesting. So Dr. Bajorn, we talked a little bit at the beginning about that blood in the urine and some of these things can be the result of other issues in the urinary tract. So we have a question here about whether chronic urinary tract infections have any correlation with bladder cancer? Prostate disease has any correlation with bladder cancer? Any correlation between some of the other problems that you might see?
So with regard to the regular, what we call transitional cell, the most common type of cancer, there's no really good data with regard to chronic infections in the development of that disease. There are some data that are suggestive, but certainly not confirmatory. However, there is another subtype called squamous cell carcinoma, and that is it's a different cell type than what we typically see, and that can be seen in patients who have either what we call a neurogenic bladder, is that the bladder does not evacuate the urine, or sometimes patients who have a diverticulum of the bladder where there's stasis of the urine, or even in patients, for example, who are quadriplegic and have a chronic indwelling catheter. That type of cell type can be seen in those patients. So yes, chronic infections can play a role, but it appears to play a major role, or a more major role in the squamous cell variety rather than the typical transitional cell variety, which is the vast majority of disease that we see.
But now we're getting into those kinds of details that it's important that you're seen by somebody who really is good at all of this.
And in fact, when patients come in, Dr. Bachner mentioned earlier that, it's a team concept, and he mentioned the pathologist, and that's absolutely critical because, for example, there's a tumor that we see, it's a small percentage, it's called small cell carcinoma of the bladder. And if the pathologist will look at it, it looks just like small cell carcinoma of the lung. It looks like a lung cancer. And it's treated completely different than the typical transitional cell carcinoma that we see. So they don't constitute a large percentage, but you need to be aware, and you need to know that they exist and be able to diagnose them correctly, because the standard chemotherapy and standard approach would not be effective in those types of tumors.
Which I think brings up an interesting point, which is sort of an evolution in the way we think about cancers in general, and not just bladder cancers, but breast cancer, all sorts of other cancers, is that we're starting to realize that the treatment really depends on the cell type, not on the neighborhood or the organ where the cancer happens to develop. Breast cancer might be a half dozen different diseases, likewise a couple of different ones in lung cancer and other cancers. So it really depends on the cell type and eventually probably the genetic characteristics of that cancer, and that'll determine the treatment rather than the fact that all bladder cancers get the same treatment.
Absolutely. In fact, we're now looking at the genetics. We're looking at a number of tumors, and we are performing analyses on these mutations that we see. And it turns out that we've seen mutations that you see in breast cancer, mutations that you see in melanoma, skin cancer. And so we are now recognizing what we call the vast heterogeneity of these tumors, that they may look the same under the microscope, but in the genetics they're completely different. And the therapies eventually to treat these will be very different as well. Right. Eventually.
Sort of, as you said, borrow a kidney cancer drug to treat this. You may end up using a lung cancer drug or prostate or something else to treat these different cancers, depending on their genetic fingerprint, as it were.
Absolutely.
Interesting. Dr. Bachner, here's an interesting question. Are patients who have non-invasive cancer at risk for developing invasive cancer down the road? And I think earlier we spoke about how it's a lifelong disease in the sense that you're never really out of the woods. You're always going to be a patient and be surveilled or be watched.
So there is a risk of progressing from a non-invasive to an invasive form of the disease. The risk of progression depends upon the type of tumor, particularly the grade of the tumor that people initially present with. Low grade or pretty normal looking cells that grow in a non-invasive tumor are more like polyps that will grow inside the bladder. These have a very low risk of ever progressing to a life-threatening form of the disease. But again, they tend to recur frequently, and that's why they require follow-up. The higher grade tumors or the early invasive tumors can demonstrate a higher risk of progressing to a muscle invasive change. And it's because of that risk that the follow-up tends to be much more stringent. We tend to perform cystoscopies more frequently. And because it is a lifelong risk, patients will be followed for quite a long period of time. But this progression risk is real, and we will see it in a percentage of folks.
What is the follow-up? How do you follow a patient? Is it scans, blood tests, urine?
All the above. So patients with a previous diagnosis of bladder cancer will be followed initially at 3-month intervals. They come into the office, have a cystoscopy to check the bladder. Urine studies are performed as well. That follow-up can be stretched out over time depending upon the risk of the disease. So if you show up with low-risk disease, low-grade non-invasive disease, and you're not showing a very rapid recurrence pattern, very quickly you're on a 1-year follow-up. Somebody with a higher risk type of non-invasive tumor, high-grade disease, because of this potential for progressing to something more dangerous, you're going to be followed pretty closely, and that's going to go on for at least a few years.
Here's a question that we get almost every time we do a panel on cancer, and it doesn't necessarily fall into any of your bailiwicks or silos here. So whatever, if any of you have something to add to this, it's kind of two sides. One is there anything in the diet that you can that you should avoid to prevent bladder cancer? And the more common question is, all right, I've developed bladder cancer or any number of other cancers. Are there supplements that I should be taking, something that I can take to help my therapy or my treatment?
We're not aware of any dietary changes that are required to try and either lower your risk of recurring if you've been diagnosed with bladder cancer, or necessarily a way to prevent bladder cancer from occurring. We're sure that there are a variety of environmental exposures that people have. Some of them may be dietary, but we just haven't been able to make that link yet. Smoking, as we've mentioned, is the most common cause, but there is a large percentage of people that will show up with bladder cancer with no smoking history. So there's something else out there. Some of these exposures have been recognized. Some occupations are at greater risk. If you work in the chemical industry, dye industry, rubber manufacturing, things like that, there may be some chemicals that you're exposed to. We think that maybe even hairdressers may be at a slightly increased risk as well because of the permanent hair dye that they may be exposed to on a regular basis. Again, not as strong a link, but there is some suggestion. So there's a variety of exposures, but as far as dietary, we don't know of any. And we hear this issue with supplements all the time. Is there something that I can take to lower the risk of things recurring? I wish I could say that there were. There had been some thought that megadoses of certain multivitamins may have been helpful, but the studies that have been done to look at that have really not demonstrated a benefit in decreasing the risk of recurring. So right now, if we can identify an exposure such as smoking, we get people to stop smoking. If you're in an occupation where you're exposed to certain chemicals, we try to get you away from that. Other than that, there's not a lot that we can point our finger to.
You mentioned hair dyes, and now is this something that the average person who has their hair dyed from time to time, or every 6 weeks, I guess, for maintenance or whatever, needs to worry about, or is it really more of an occupational hazard, the person who's exposed to it on a day-in, day-out basis?
These are epidemiological studies, and it really appears to be the occupation of a hairdresser who's exposed on a regular basis. This is an extraordinarily complex question for which, and it's very difficult to discern out. We and others are collaborating on this, and it's called gene-environmental interactions, that there are probably predisposition genes that we all have, and some of them have been identified in what we call these genome-wide association studies, where you take thousands of patients and then you look at thousands of genes and you identify that there are some genes that increase the risk, but the risk is a 1.5 to 2-fold risk. Now what we're doing is we're actually having patients fill out surveys, and we're looking at the environmental exposures. Where do they live? What is their smoking exposure? What is their occupation, et cetera? And now we're just starting to look at what we call gene-environmental interactions to see, can we identify the genetic susceptibility and the exposure to that particular carcinogen. They're very complex studies. They require thousands of patients, and the technology now is just evolving to be able to do that. And there are a number of groups in the United States and in Europe now that are combining their efforts to identify these gene or gene environmental interactions.
Dietary modifications can be critical as far as patients undergoing therapy and having symptoms related to their treatment. So I very often give patients specific recommendations as far as limiting foods or drinks that they're consuming that can just exacerbate their symptoms. There's an entity called Interstitial Cystitis, which is an inflammatory condition of the bladder, and there's a whole host of different liquids and foods that can exacerbate that, and I actually use that in clinic very frequently to help patients through treatment.
Interesting. Let's go back to the supplement for a second. Even though we may not have identified any supplements that really make any difference, the fact is that many, if not most, of your patients will be taking something. I think it's important to emphasize to people that they need to tell you what they're taking, because they may or may not, the supplements may or may not help, but they might also interfere with, for example, chemotherapy.
Oh, absolutely. I think if I were to make one recommendation for patients, and that is, this is a smoking-related disease, and not uncommonly I will see that patients are still smoking either after surgery or during the time of chemotherapy. And that is the one thing, if we can, we have a very active smoking cessation program because tolerance to chemotherapy is impaired with continued smoking. But absolutely, if from the point of view of interactions, I have had the experience where patients are taking what they call an immune stimulator, only to find out that they develop an infection. Or I've had patients, for example, take shark cartilage and they have gastrointestinal bleeds. This is really critical. These it sounds like apple pie and motherhood, that when I'm taking an immune stimulating drug, or I'm taking a vitamin, but in point of fact there are a lot of drug-drug interactions. These are drugs that you're imbibing, even if it goes under the name of a vitamin.
Or natural. Don't make the mistake to think that something that's natural can't cause any harm, right?
Yes, absolutely. We all know that.
Well, a lot of people don't realize poison ivy is as natural as it gets, or so is snake venom, but it doesn't necessarily mean it's good for you. Dr. Kohlmeyer, let me go back just for a quick second, just so we can finish up on radiation, because now all you have to do is turn on the radio and hear CyberKnife and IMRT, and I mean all sorts of different gamma knives and different things. Do any of these play a role, or is this mostly marketing, or what's important when it comes to radiation therapy?
Radiation therapy for bladder cancer specifically is really not succumb to CyberKnife or some of the other direct consumer advertising that other cancers have been susceptible to. But we have used intensity modulated radiation therapy for bladder cancer, IMRT. The challenge with using IMRT, basically what it is the radiation oncologist really sort of paints the dose where we want it to be. So we can really sort of carve out areas or organs that we want to protect. The one critical aspect of IMRT is you really have to track the organs that you're targeting, because if they move out of the radiation area, they can be either underdosed or overdosed depending on the motion. So IMRT has to be done extremely carefully with bladder cancer patients, and I think that it really should be done only when using image-guided techniques such as the gold coils, or sometimes you can have CT scans done immediately before each radiation treatment to locate the bladder and so on. CyberKnife techniques have not been routinely used for bladder cancer, and I would say that they would be investigational at this point.
In the time that we have remaining, I always like to sort of ask each of you for a little bit of where you see the future going here. I've, like you guys, maybe not you, Dr. Kohlmeyer. I've been doing this for 32 years as a medical journalist, and I've seen the world of oncology evolve dramatically. And in the last certainly 5 years to 10 years, it has really changed, and it's an exciting time. There's a lot of stuff going on that I'm not sure everybody realizes how much progress is being made here. Where do you see the future going here now vis-a-vis bladder cancer, for example?
Well, I'm going to really focus on the metastatic and novel treatments, but there's a tremendous effort right now called the Cancer Genome Atlas, and we and others are pooling all our resources, including the National Cancer Institute, to be able to dissect out these tumors, and we're using multiple platforms. We're looking at the DNA, and then after the DNA is the microRNA, and then after that is the regular RNA, and then after that is the protein. Highly, highly complex systems, as we all know. But I see us working on not just specific genes, but families of genes or pathways of genes that affect the tumor and being able to intervene with those. And eventually I think we'll be able to do that with the RNAs as well. That's one aspect. I think the other aspect is actually the host, the patient themselves. We know that the tumors come from the same DNA that the patient has. And so there's a tremendous effort now on what we call pharmacogenomics, and that is that each patient the patient's DNA is in the host, and we can look at the patient's DNA as a surrogate for the tumor DNA, and then sometimes, and I think that we will eventually see that they're probably cooperative in some ways. And we're just seeing the early part of that. I think that's number one, and that's evolving. I see that in the near to intermediate future. The other area I think is utilizing what we already know, and that is, for example, when we look at multimodality therapy, we know we've had the lessons of how to do it well, and yet we see that it's not done well all that frequently. And this is where we look at outcomes of each modality contributing to the best that they can across the board nationwide, and that these outcome analyses are really necessary. So I think aside from the biology, I envision that our disciplines will be much more involved, team-based care, and I think that is a great thing for patients.
And Kohlmeyer, where do you see radiation going?
I completely agree. I think some of the most profound impacts on future treatment for bladder cancer is really going to be on genetic characterization of tumors and selecting patients, not only to determine which tumors are more aggressive, which tumors are less aggressive, but which tumors are going to respond to radiation therapy and chemotherapy, and which patients are not going to respond and should have surgery. I think these questions are really critical to find the answers to. I think as far as once we make the decision that radiation therapy and chemotherapy is the way to go, really doing that treatment as carefully and accurately as we can is really critical, and we really need to improve and continue to improve upon that.
Dr. Bachman will give you the last word. I think sometimes people think of how much more evolution can surgery undergo, but that's not the case.
Well, as a surgeon that does a lot of extensive surgery for this type of disease, I think where we see the future is doing less surgery for this kind of disease. And what I mean by that is we know that the outcomes of this particular cancer are better when we pick it up at an early stage, at the earliest stage, meaning the non-invasive stage. And I think that this explosion of information, the genetics about the tumor, the genetics about people who are susceptible to getting the disease is all going to be combined to allow us to begin to start screening people more effectively as well. What we want to do is we want to find this tumor at the earliest possible stages and eliminate the need for this type of extensive surgery. So I'd like to see myself out of business, if you will, from a surgical standpoint. I'd become a fly fishing guide or something like that. But I think that this genetic information is going to lead us to become much more sophisticated about this.
I have a feeling you're fly rod is going to gather cobwebs for a while. I want to thank all of our panelists. I think this has been very interesting and informative. I hope it has been for you as well. And thank you all, and get home safe. Thanks.